About 8% of Americans have chronic kidney disease. We know that increases risk of myocardial infarction and stroke. Now, what about cardiac prevention in that particular population? Are there particular effects that might make it either pro or con in terms of whether you treat or not? Well, coming up in the March 26th issue of JACC, there is a paper, and it's on cost effectiveness of statins for primary cardiovascular prevention in chronic kidney disease. And I am with the author, Kevin Erickson, MD, Stanford University. Yep. And this is a good paper. This is an interesting topic and a great issue. Why did you do it, first off? Why the study?
Two big reasons. As you mentioned, chronic kidney disease is very common. It's estimated to be prevalent in up to 8% of U.S. adults, and chronic kidney disease is an independent risk factor for cardiovascular events. So cardiovascular disease is really a big issue in patients with chronic kidney disease. Most people, when they think of chronic kidney disease, think of end-stage renal disease and dialysis. Right. Patients with chronic kidney disease are far more likely to die of cardiovascular events than they are to progress to end-stage renal disease or dialysis. A number of studies, primarily secondary analyses of large statin trials, have shown that statins are effective in preventing cardiovascular events in patients with early stage 3 chronic kidney disease. And the recently published SHARP trial showed that they're also effective in more advanced stage 4 chronic kidney disease. So guidelines, however, are conflicting about when to use statins in chronic kidney disease. Some, such as the ATP3 guidelines, don't consider chronic kidney disease to be a risk factor, while others, such as American Heart Association and National Kidney Foundation guidelines, say that chronic kidney disease should be considered a coronary heart disease equivalent, similar to something like diabetes, where essentially all patients are placed on statins. So when you're thinking about giving to statins to a large number of people who are otherwise relatively healthy, it's important to consider not only the costs of statins, but also the potential for toxicities. And we did just that. We created a decision analytic model that weighed the potential benefit of statins against not only the economic costs, but also the potential for toxicities such as rhabdomyolysis, which is more common in patients with chronic kidney disease, and downstream long-term toxicities such as diabetes or permanent memory loss.
So what was the basis for the analysis? How many patients? What did you use?
So we, again, it was a decision analytic model. All of our inputs came from published literature. We primarily used our efficacy evidence from the pravastatin pooling project, in particular a secondary analysis of that project that looked at patients with chronic kidney disease, although there have been a number of meta-analyses showing similar treatment effects of statins in patients with chronic kidney disease. We had the effect of statins gradually decreasing as patients progressed towards end-stage renal disease because, as you might know, there's been a number of trials in patients with end-stage renal disease that show that statins aren't beneficial there. So we incorporated that graduated decline in efficacy of statins. We found a number of things. In our base case, we looked at 65-year-old men and women with chronic kidney disease, mild to moderate hypertension, who, unless chronic kidney disease were considered a coronary heart disease risk equivalent, wouldn't be placed on statins. We looked at cheap generic pravastatin and found that in the base case, in men and women, statins cost in men $18,000 per quality adjusted life year saved, and in women around $34,000 per quality adjusted life year saved, which compares favorably to many commonly accepted treatments. When we looked over a broad range of baseline cardiovascular risks, low-cost generic statins were cost-effective in essentially men of all ages with and without hypertension, and women as long as they had hypertension. However, when we look at statins generic statins at average retail costs, there are a number of groups where statins cost more than $100,000 per quality adjusted life year saved, including women without hypertension and women with hypertension who are younger and men without hypertension. So I would say that the take-home point from that analysis is at low cost, generic statins it's worth considering their use in a wide range of patients. However, at current retail prices, a risk-based algorithm similar to something like that advocated by ATP3 guidelines might be more optimal. And finally, when we looked at some of these downstream side effects,
I was going to say safety.
That becomes important. The potential for rhabdomyolysis is our analysis was sensitive to that, particularly in younger patients, and also the risk of things like diabetes and memory loss, again, becomes an issue when looking at patients at lower baseline cardiovascular risk. So I think if statins are used in potentially a wider range of patients with chronic kidney disease, it will be important to monitor for things like rhabdomyolysis, and also it'll be important for us researchers to have a better understanding of the actual incidence of things like diabetes and memory loss.
And Dr. Erickson's paper is showing up in JACC. It's March 26th issue, so please go see your issue of JACC and read more about this and all the other reporting from JACC and what we call JACC in a flash in CardioSource World News. I'm Executive Editor Rick McGuire.